Assalamu alaikum. Let's dive into ARDS, acute respiratory distress syndrome. In ARDS, to remember the risk factor for ARDS, you can remember these mnemonic past. For ARDS, you have to look at the past. That is, new pancreatitis, aspiration pneumonia, sepsis, and trauma. And inhalation is another risk factor, and that's it. So direct is pneumonia and inhalation, and indirect is sepsis, pancreatitis, and trauma. So direct lung injury, indirect lung injury can happen. There may be inflammatory cell activation, increased permeability, increased fluid and cytokine leakage into the alveoli. Inflammatory cell activation and increased permeability, fluid and cytokine leakage into the alveoli. Pathophysiology is decreased lung compliance, which will increase work of breathing. Decreased lung compliance, alveolar flooding, which will increase the work of breathing. Severe VQ mismatch, intrapulmonary shunting, severe hypoxemia. So decreased lung compliance, severe hypoxemia, and increase hypoxic pulmonary vasoconstriction, which will increase right ventricular afterload, and acute pulmonary hypertension. These are the pathophysiology that decrease lung compliance, severe VQ mismatch, which will cause severe hypoxemia, and increase hypoxic pulmonary vasoconstriction, which will increase right ventricular afterload and acute pulmonary hypertension. Diagnosis is new bilateral alveolar opacities. New bilateral alveolar opacities within 1 week of the alveolar insult. New bilateral alveolar opacity within 1 week of alveolar insult. Edema not explained by cardiac failure or volume overload. Edema not explained by cardiac failure or volume overload, and hypoxemia with PaO2 by FiO2 less than 300, and hypoxemia PaO2 by FiO2 less or equal 300. In ARDS, there may be lung protection, there may be ventilation, there may be oxygenation. So in mechanical ventilation, lung protection, limit alveolar distending volume, In ARDS, tidal volume should be kept in 6 ml per kg, and plateau pressure should be less or equal 30 centimeter. So VT would be 6 ml per kg, and plateau pressure would be less or equal 30 centimeter of water. Ventilation is tolerable permissive hypercapnia, increase PaCO2, tolerable permissive hypercapnia, increase PaCO2, decrease pH to avoid excessive tidal volume, and oxygenation, set lower feasible FiO2, and our goal is to keep the SpO2 is 92 to 96 to avoid oxygen toxicity. Supportive care treat underlying etiology, source control like sepsis, prevent iatrogenic harm, negative fluid balance, timely extubation, minimize sedation. Corticosteroids select patient with moderate to severe early ARDS. So for moderate to severe ARDS, give steroid. Mortality rate 40% in the hospital. Death mostly due to multi-organ failure, morbidity rate 50% with chronic cognitive impairment, physical disability 25% with pulmonary dysfunction, restriction and decrease DLCO. So for ARDS, mechanical ventilation, tidal volume should be at 6. Plateau pressure should be 30 or below 30. Ventilation is total permissive hypercapnia, PaCO2 is high, pH is low, excessive tidal volume, and oxygenation set lowest feasible FiO2. Okay, look at this chart. It's a very must know chart. For ARDS syndrome, initial ventilator management. Initial ventilator management. Intubation oxygenation FiO2 is 100%, PEEP is 5, VT is 6, and respiratory rate is 14 to 18 per minute. So whenever you find a ventilator and the patient's diagnosis is ARDS, so set the ventilator in that way, like FiO2 is 100%, PEEP is 5, VT is 6 ml per kg, and mm, ideal body weight and respiratory rate is 14 to 18 per minute. If adjust oxygenation, adjust ventilation. When we need to adjust oxygenation, if PaO2 is more than 100, if PaO2 partial arterial oxygen is more than 90, if there is hyperoxia, FiO2 should be decreased. If there is hypoxia, PEEP will be increased. So hyperoxia, FiO2 will be decreased. Fraction of inspired oxygen would be decreased. If there is hypoxia, PEEP will be increased. Now, this is the adjustment of the oxygenation. How you can adjust ventilation? If PCO2 is high, pH is less than 7.25. If PaCO2 is high and pH is less than 2.5, pH is less than 7.25, increase respiratory rate and increase tidal volume as a last resort. So the respiratory rate should be increased if PaCO2, carbon dioxide, is more. If carbon dioxide is less, then decrease respiratory rate, decrease tidal volume, and sedation is the last resort. So ensure lung protective ventilation, avoid alveolar overdistension, evaluate lung complex measure, plateau pressure with inspiratory hold. Measure plateau pressure with inspirator hold. Our goal plateau pressure is less than 30 centimeter of water and tidal volume and the decreased tidal volume and adjust PIP. So this box is a must know for uh, controlling the ventilator in a patient suffering from ARDS. Now, Now, look at this question first. This 35-year-old woman, this 35-year-old woman is evaluated at the bedside due to new onset, rapidly worsening shortness of breath and hypoxemia. There you go. He was admitted for sepsis. Okay, so we have found the risk factor. Okay, temperature is high, blood pressure bit low, tachycardia, tachypnea, oxygen saturation 84% on NRV. FiO2 is 90%. The patient appears anxious and labor respiration. Okay. Normal JVP, warm extremity, pulmonary examination show faint, weight crackles diffusely, faint, weight crackles diffusely. The patient is intubated. She is transferred to the ICU. Chest X-ray show this. ECG shows sinus tachycardia. Cardiac is troponin is normal. Bedside transthoracic echocardiography reveals hyperdynamic left ventricular contraction, and trace MR. Blood culture negative, ground stain negative. Which of the following tests is indicated for at this time? Which of the following test is indicated at this time? So, according to the features like ARDS, abnormal chest X-ray, are for respiratory rate more than 30, PaO2 or FiO2 ratio, and symptoms of heart failure. Looks like symptoms of heart failure or cardiac failure, not due to cardiac cause or volume overload. So this is ARDS, clear cut ARDS. So in here, we do not need to do any additional testing for diagnosing and this ARDS. So this patient has sepsis due to ascending cholangitis, okay, and their pulmonary edema. She developed pulmonary edema, wet crackle, new bilateral fluffy opacities on the chest X-ray. New bilateral, there is fluffy opacities on the chest X-ray, and there is wet crackles, and it is unexplained by volume overload or cardiac failure. Its symptoms is not explained by volume overload or cardiac failure, given the normal JVP and left ventricular function on echocardiography. These non-cardiogenic pulmonary edema results in severe hypoxemia and requiring high FiO2. Timing, chest X-ray, euvolumic status, hypoxemia are consistent with ARDS. So chest X-ray, euvolumic status, and hypoxemia are consistent with ARDS. A rapid source control like endoscopic stone retrieval and antibiotic therapy, but can entirely eliminate the risk but cannot entirely eliminate the risk of the ARDS due to uncontrolled hyperinflammatory response. Invasive procedure like biliary instrumentation also transiently increase the systemic inflammation. When lung injury has clear etiology, ARDS can be diagnosed with no further testing. So, as these lung injuries show clear etiology, a non-cardiogenic pulmonary edema, so these ARDS can be diagnosed with no further testing. A brief cardiac screening like ECG, TROPI, BNP, bedside echo is performed, and survival is maximum when specific intervention like low tidal volume, prone positioning, and implemented promptly. Therefore, early diagnosis based on the symptom recognition rather than extensive diagnostic testing has time critical change. Okay, look at this question now. This 26-year-old man is evaluated in the ICU 24 hours after being admitted with ARDS. He has ARDS due to why these ARDS due to why opioid overdose and aspiration. I have said you aspiration. Look at the past. So aspiration of the gastric contents. These the patient intubated, sedated, okay, receiving mechanical ventilation, okay, hemodynamic stable after full liter of normal saline. Okay, good, well and good. The patient is receiving low tidal volume. Ventilation is at 8 ml per kg. FiO2 is 50%. PIP is 12. The patient ventilator interaction is synchronous. He has acidosis, a respiratory acidosis. pH is low. PCO2 is high. PO2 is low. PO2 is not low, PO2 is normal. Chest X-ray show patchy bilateral opacities and pulmonary edema. So patchy opacity pulmonary edema looks like ARDS, and in here they have told that this patient has ARDS. And echocardiography show left ventricle normal left ventricular function. And which of the following intervention would be most helpful to promote recovery of the respiratory failure? So in this question, we need to do avoiding positive fluid balance to reduce pulmonary edema. There is one thing you can say, that PCO2 is higher. Why we are not increasing respiratory rate according. Okay, now this patient has ARDS due to aspiration pneumonitis, one of the cause of one of the risk factor of ARDS. The hallmark of ARDS is neutrophilic lung inflammation with increased vascular permeability leading to pulmonary edema in the absence of cardiac failure or volume overload. However, once ARDS is established, excessive intravascular volume serves only to exacerbate fluid escape, leading to worsened pulmonary edema and delayed recovery. Fluid balance num, refers to the net sum of all fluid intake and output from the time of admission. Patients with ARDS often have initial positive fluid balance, volume resuscitation for sepsis, blood transfusion for trauma. During hospitalization, a conservative fluid strategy aimed at achieving a neutral or negative fluid balance accelerates recovery from ARDS with a trend toward the improved cervical rate, like dry lung is happy lung. Our goal is to minimize intake and promoting removal, avoiding unnecessary fluid bolus and concentrating intravenous fluid drip and promoting removal like diuretics and renal replacement therapy. So our main concern is these two, like dry lung is happy lung. Patients with refractory hypertension septic shock should be assessed for fluid responsiveness prior to blind volume loading via passage, passive leg raise to stimulate fluid bolus, via passive leg raise to stimulate fluid bolus. Vasopressor may be required to support hemodynamics to permit volume removal. Okay, look at this question. This patient brought to the hospital from a nursing due to confusion, high grade fever. Okay, uh, undergoing cystoscopy with removal of bladder polyp. Okay. On admission, there is respiratory failure requiring endotracheal intubation. Mechanical ventilation is initiated. Okay, IV volume, antibiotic is given. Tidal volume 370. Respiratory rate is more. PEEP is 5. FiO2 70%. Inspirator plate to pressure less than 30. Inspirator plate to pressure is less than 30. It is normal. Chest X-ray reveals extensive bilateral alveolar opacity. pH 7.4. PCO2, it is alkalosis, respiratory alkalosis. PO2 is less than 60. If PO2 is less than 60, we need to increase the PEEP, increase positive and expiratory pressure, increase PEEP. Look at here, PO2 is low, so below 60 hypoxia. So in ARDS patient, PaO2 is low, increase PEEP. Okay, look at this question. Third, a 43-year-old acute pancreatitis, one of the risk factor of ARDS. Initial ventilator respiratory rate 14, tidal volume FiO2 and PEEP is 10. 10 minutes of after the patient intubated, blood pressure is normal. Okay, now pH is 7.32, PCO2 is higher, and PaO2. Okay, look at here PaO2 is higher, like hyperoxia, so decrease FiO2. Look here, PaO2 is more than 90, decrease FiO2. Okay, next question. Okay, look at here, 44-year-old man admitted to the hospital due to severe abdominal pain and vomiting. Okay, 10 shots of whiskey daily for the past 6 months. He has no other medical condition. Pancreatitis. Okay, one of the risk factor, cannot get enough here. Okay, echocardiography, major valvular disease, undergo mechanical ventilation. What treatment strategy is the most likely to decrease the risk in patient hospital mortality? Preventing alveolar overdistension. Preventing alveolar overdistension. Mechanical ventilation. Our goal in ARDS is to provide adequate oxygenation and ventilator without causing further injury to the lungs. Our target tidal volume is 4 to 6 ml per kg of the body weight. In ARDS, a significant number of alveoli remain collapsed despite positive airway pressure, and any tidal volume delivered by the ventilator is distributed to the remaining open functional baby lung. So, low tidal volume ventilation prevents overdistension of the alveoli, and compared to use of high tidal volume, more than 8 ml per kg, improves mortality. Low tidal volume improves mortality in patients with ARDS, and higher tidal volume excessive stretching of the damaged and delicate alveoli to further compound the lung injury. Okay, okay, the final question. This X-ray looks like, okay, I'm reading this stem, shortness of breath, okay, alcohol withdrawal, okay, mm, chest X-ray, IV antibiotic. 12 hours after he developed shortness of breath, respiration is higher, oxygen saturation is 80% on NRB, oxygen saturation is 80% on NRB. Okay, so it looks like ARDS. So decreased lung compliance. So decreased lung compliance, ARDS, these exchange result in impaired gas exchange leading to hypoxemia, impaired gas exchange leading to hypoxemia, and due to prolonged ventilation perfusion mismatch, impaired gas exchange leading to hypoxemia due to prolonged ventilation perfusion mismatch, and decreased lung compliance ability to expand due to loss of surfactant, and increased stiffness and weight of the edematous lung, and increased pulmonary artery pressure due to pulmonary hypoxic vasoconstriction and destruction of the lung parenchyma. During treatment, mechanical ventilation, positive airway pressure causes compression of the arteriole and further contributes to increased pulmonary arterial pressure. Okay, so in here, decreased lung compliance will increase work of breathing and thus help in ARDS. Okay, that's all about ARDS. Hope you